Just seeing if yes. So we are live now on YouTube channel after a very long time, and of course, I don't remember when was the last time I was live on YouTube. Maybe 1 year, no idea. Right? Pleasure to see you all now as we are entering into a new year 2022 and newer milestones for the AYMPT in various social media platforms. We reached 1,000 subscribers on Instagram, and we also crossed the 7,500 followers on Facebook, growing into a largest manual therapy academy in the world, not just in India. Largest not in terms of just the followers or the number of subscribers, but the most important thing is largest in terms of the numbers of hours of education that we provided. No other manual therapy academy in the world has provided more than 1,500 webinar hours throughout these 2 years of COVID-19. And AYMPT is indebted to keep continuing the wonderful work of providing knowledge and education in the field of manual therapy. Of course, the most challenging part in manual therapy is the direct hands-on delivery, and we need hand holding. Like, for example, you want to do a palpation, you want to do a physical examination, you want to do tissue texture or the behavior evaluation, mobility examination. In manual therapy, we require direct transfer of skill. But remember that it is also about the sincerity of the participant when they are applying the techniques and the way they are reviewing their techniques to see for betterment, whether I am doing it correctly or not. Okay, so that conscious effort from the participant and an ongoing communication with the instructor in an online platform itself, and a follow-up with case webinars. So whatever techniques have been learned, so either the technique videos have been sent to the instructor for verification, or application on patients and the patient's recovery and improvement is shared as a case webinar with the instructor. We have evolved newer methods of transfer of knowledge in an online platform, and AYMPT has broken all the records. So it's a pleasure on behalf of the academy, as the chief instructor of the academy, I felt the need that we have to clarify a lot of unsolved queries in manual therapy. Before that, this YouTube channel of AYMPT, you can see now that there are nearly 440 videos which are publicly available with free access, and more than 200 videos are more than 1 hour duration. So remember not to miss the content that is shared widely and publicly in this YouTube channel. And these have been the discussions, the interactions, the demonstrations during the online certification courses and the workshops that has been conducted in the past 2-3 years. Of course, the content is shared in this channel right from 2010 onwards. You can also see a few videos which are shared from 2006 also. So what I would wish to highlight today by coming live, the most important aspect is the interaction. So I request the participants to throw up your questions and queries so that I can expand upon that and provide my inputs. You can put your comments through the live chat. So you can definitely ask me your questions as your comments so that I can get through with what exactly is in your mind. Popularly, first I want to clarify some of the um, ground reality for manual therapy. First and foremost, manual therapy is not a technique. It is not a treatment approach. Manual therapy is a professional discipline. So that word, the two words actually determine equivalent to physical therapy. Because you have doctorate of manual therapy itself. Okay? You have the Ola Grimsby Institute providing in Norway, Sweden and other regions in Europe, Doctor of Manual Therapy program. So it is a actually professional discipline. Manual therapy is equivalent to physical therapy. Okay? But then what made that manual therapy to be closely associated with physical therapy is because over the years, the techniques of manual therapy which are in their foundation, basically the articular techniques, manipulation and mobilization, primarily came from contributions by physical therapists. Because of that, International Federation of Orthopedic Manipulative Physical Therapists is the first organization in the world for manual therapy. Okay, in a broader spectrum. Of course, was created by physical therapists from various countries. Then we come to the treatment approaches. In manual therapy, as I was highlighting manipulation and mobilization as articulatory techniques, joint-based treatment techniques, treatment approaches. Similarly, we have multidisciplinary and multifaceted treatment approaches. That means you can address articular system, you can address myofascial system, you can also address the neural systems. These are the three broad categories of impairments what we are trying to evaluate in manual therapy. The interesting part here is, same way multifaceted treatment approaches is also available in two parallel professions, which is the osteopathy and chiropractic. Both have been from US, and so osteopathic techniques is also manual, under manual therapy. Chiropractic techniques is also under the manual therapy, and physical therapy techniques are also under the manual therapy. So it became like an umbrella under which all three professions, including even massage therapy. There are massage therapy licensed massage therapists in US. So we have professions for physical therapy, massage therapy, chiropractic, osteopathy, and also separately for manual therapy also. So this is the interrelationship between all this. So all these four come under the manual therapy. There are, in chiropractic for example, other than manual therapy, there are many other methods that are used, including electrical modalities. Osteopathy also. Massage, mostly it is manual, but there are some mechanical vibrators and electronic massage devices. So you can have massage therapy also having some amount of non-manual techniques. Okay, physical therapy has largest manual therapy techniques, but you have mechanical techniques and machine-related techniques included under its treatments. So try to understand this term manual therapy. If you are using the term manual physical therapy, which is commonly used as OMPT, Orthopedic Manual Physical Therapy, thanks to the American Academy of Orthopedic Manual Physical Therapists, was the first to use that. And there is OMPT subgroup in every national physiotherapy associations. Their primary purpose is to see that physical therapists who are trained in manual therapy can identify themselves as manual physical therapists. So it's like a specialization it has become. Next we are coming to the treatment approaches where we are talking about terminologies like manipulation, mobilizations. Remember, manipulation means a technique. Manipulative therapy is a treatment approach. Manipulation is a high velocity, low amplitude thrust techniques. Manipulative therapy means including the thrust techniques, many other techniques may be combined and used as a therapy program. You can't use these terms interchangeably. If I am telling that a patient has a cervical facet joint lock, facet joint dysfunction, and I am giving manipulation, it means that it's a treatment technique. Whereas if I am telling I gave him manipulative therapy, it means that it may be manipulation, or even without the manipulation, even if I am giving mobilization also, it is included under manipulative therapy. I can give joint mobilization, I can give myofascial release, I can give neural mobilizations. All of them are included under manipulative therapy. So that we should know that first. Many resource persons do not emphasize this distinction between these terms. If I am telling that I gave manual therapy for the facet joint lock, it is an inappropriate sentence, because what you actually gave is only the manipulative therapy. You can't give manual therapy. Then what to do with that? Many of them are using. Remember, I should mention it as I applied the manual therapy, or I used the manual therapy for the neck pain or the facet joint lock. So that is the difference. We can only use it, we cannot give it. Okay? A treatment approach, we can give that treatment. So remember the difference there. Okay? So how do you distinguish a broader manual therapy as a profession from a manipulative therapy, which is a treatment approach? Basically, the difference lies in use of adjunct techniques. So you might evolve manipulative therapy beyond its definitions, extend its scope of practice, and combine it with many other techniques. Then it becomes the manual therapy. Best example of such is motor control, or what is called as the neuromuscular training, which is emphasized increasingly as part of a very effective adjunct for manipulative therapy. So then what happens is it becomes a manual therapy rather than a manipulative therapy alone. Okay. So manual therapy is much broader and it is a professional discipline level. Okay. So manipulative therapy is a treatment approach level, manipulation is a technique level, mobilization is a technique level, and you can have many of the techniques. To name a few, historically we have joint mobilization, which was described by Calton-Bond, John Mennel, James Mennel, and then with Jeffrey Maitland for joint mobilizations. Similar method of mobilizations, what Maitland described was either physiological mobilizations like flexion extensions, or accessory mobilizations like the glides, medial, lateral, anterior, posterior, or distraction compressions. Either of this was under the joint mobilization. But Robin McKenzie, he concentrated more on the physiological aspects alone. And he expanded his technique-based school of thought, called as the mechanical diagnosis and therapy, which involves evaluating a patient by positions and repeated movements, which might be flexion extension, abduction, adduction. If it is spine, it is the lateral flexion, it may be with rotations, in order to classify the patients into postural dysfunction and derangement syndromes. So McKenzie's concept is basically revolving around the physiological movements. Even the derangement syndrome, we look for the centralization and peripheralizations and we base our treatment decisions. The accessory part alone or physiological part alone is Jeffrey Maitland. Okay, so both of them you can use. Where that comes as the grades of mobilization. You have the grade 1, which is small amplitude beginning of the range. Grade 2, which is the large amplitude beginning of the range. Grade 3, large amplitude at the end of the resistance. And grade 4, small amplitude at the end of the resistance. And grade 5, from the end of the resistance, a quick high velocity low amplitude thrust. It's not an oscillatory technique, it is a unidirectional technique. Grades of mobilization was explained by Jeffrey Maitland, also by Kaltenborn, of course, earlier than Maitland. And later we see that Mackenzie took the physiological side, whereas the physiological grades of mobilization and then accessory grades of mobilization both were taken by Maitland. Kaltenborn emphasized on only the accessory part and he gave the grades of mobilization. So what we need to know is Brian Mulligan later came up and he said, why can't we combine the accessory mobilization with the physiological mobilization? So that means Maitland was telling give the glides separately and he was telling that mobilize the movement after giving the glide. Mackenzie was telling evaluate by movements or evaluate by the positions and then check the responses and prescribe the movements. Whereas Brian Mulligan told, why can't we give the mobilization and ask the patient to do the movement? So the mobilization with movements, where he combined and integrated accessory mobilization with the physiological movements. So that's the relationship here between Robin Mackenzie, Jeffrey Maitland and Brian Mulligan. Popularly known as mechanical diagnosis and therapy, mobilization or joint mobilizations, and mobilization with movements. They are major contributors to the articular system or the impairment based reasoning in manual therapy. Of course, Australia, New Zealand, okay, these are the area where these three evolved their approaches. Further, to join these articular aspects, we have Brian Edwards, who emphasized the role of one physiological movement with another physiological movement. So that is, he was not interested in combining the accessory with the physiological, because if you combine accessory with the physiological, it becomes Mulligan's approach, the mobilization with movements. So he said we can combine multiple physiological movements together. So if I am doing flexion extension of the wrist, in the flexed position I can also do ulnar and radial deviation, and again I can add pronation or supination of the forearm also to influence the distal radial ulnar joint. So he coined the term combined movements. So either accessory mobilization or physiological mobilization, you should not stop with just directing in one movement. We should add combinations of movements because in our daily activities, we don't do individual movements. We do in a three-dimensional plane, combining all the movements. So Brian Edwards' concept of combined movements also adds up to this whole spectrum of articular system for impairment-based reasoning. Thrust manipulation was used by osteopaths, was used by chiropractors, was also described by physical therapists like Maitland himself. He described the thrust manipulations. In addition, the orthopedic physician James Syriax also explained the thrust manipulation. The difference in what is called as various thrust manipulation, okay, when you are looking at an osteopathic perspective, they are more into influencing the functional aspects through structural malalignments. So there's a structure to function interrelationship there in osteopathy. Whereas in chiropractic, predominant focus is subluxation and anatomical malalignments. So that is how chiropractic is much more structural focus than the osteopathy, which is also having the functional focus. When you are seeing for Maitland, he emphasized on the biomechanical reasoning behind the thrust manipulation. Of course, after clearing about the red flags, which is the contraindications. So what's important here is also to see that the further thrust manipulation, which was explained by James Reax, was predominantly for reducing the disc material and also for loose body reductions, rotation and distraction techniques, even for articular degeneration, or it is for sciatica. So remember the full spectrum of articular techniques there. Whereas when we are talking about myofascial techniques, they are much younger when compared to the articular techniques. Under the broader spectrum of manual therapy, even soft tissue massage comes under myofascial techniques. James Reax also advised deep transverse friction massage. And you have various experts who gave soft tissue treatments like Robert Main. But when we come to the muscles and the myofascial dysfunctions, predominant contribution by Travel and Simons, who coined the term myofascial trigger points. It revolutionized the approach towards myofascial impairments. Vladimir Janda, he was predominantly concentrating on the tightness of muscles, shortening of muscles, and lengthening of muscles, inhibition or overactivity of the muscles. He was a neurologist. He was telling about stretching as a treatment for muscles because it's for tightness, which is the pathomechanics he was actually proposing as the cause of dysfunctions. So when you are seeing for the further evolution of techniques, from osteopathy, lot of myofascial techniques were taken into a separate domain of impairment-based reasoning. Some of them include the myofascial release techniques, which were again explained by Joseph Barnes, and you have Carol Mannheim. Many of these osteopaths, they are also trained in physical therapy, so they wrote textbooks on myofascial release techniques, predominantly addressing the trigger points, which may be active or latent or satellite trigger points, by giving gross, specific and direct myofascial release techniques. They're very gentle techniques and they are passive techniques. When you are looking for the other techniques, which sometimes may be selectively indicated in patients who have muscle spasm, we have the contribution of Lawrence Jones and his associates to develop a positioning of comfort or positioning of ease to make sure that the spasmodic muscle relaxes, because we are not elongating the muscle, we are not activating the muscle, we are keeping it in relaxed and comfortable shortened position. So that was positional release techniques, which again is a big breakthrough when it was imbibed from osteopathy into the mainstream manual therapy. Another in the list, in lining up with the myofascial group of techniques, is the muscle energy techniques. Osteopaths explained predominantly with articular oriented approach, using the muscle contraction for mobilizing the joints, correcting the dysfunctions of joints using activating a tight muscle so that the muscle gets lengthened. That is called as the post-isometric relaxation. Or activating the antagonist of a muscle when this muscle is in spasm. So that was termed as the reciprocal inhibitions. Myofascial techniques, they did not much explore the application of muscle energy techniques. So that means muscle tightness, especially, okay, myofascial dysfunctions. But physical therapists were quick to adapt that principles and use it for a spectrum of people who had muscle tightness. So muscle energy technique involves both for myofascial dysfunctions and also for articular dysfunctions. It is an active force is there, but the passive positioning is there and passive progression is there. So it's combining with active and passive. Otherwise, positional release is also passive, myofascial release is also passive. Next, when we are coming to the improvisation of adapting these techniques, other than right from the osteopathy alone, integration from physical therapy. So motor control retraining, separately again as kinetic control, globally it has been, the training is provided. But motor control retraining incorporates the neuromuscular principles and it's a purely active approach in the addressing the myofascial impairments. So it's a very, very unique aspects that we have at evolution in the myofascial group of techniques. To add on to this list, of course, there are many more improvisations which have been done, especially by AOMPT itself. I'll first explain what is the existing one and then I will tell you how the evolution of techniques in AOMPT came into existence. So the articular and the myofascial is completed. Now we have the neural. Initially started with the works of Robert Elvey and then popularly understood as nerve stretching. Later came into that existence of neural tension because of the sole contribution by David Butler. He also coined the term neural mobilization and he incorporated the grades of mobilization of Maitland for nerves also. Only difference is joint mobilization means you are going to mobilize only the wrist, but if the same is a median nerve mobilization, you will position it and then you will do the graded mobilization for the wrist. So this position, combined position, loads the median nerve. So David Butler was quick to explain how you can utilize this neural mobilization judiciously for patients with nerve-related symptoms. But however, the whole world was getting around with the neural tension, and the patients may not improve just with loading the nerve, elongating forces on the nerve. So Michael Shacklock, who is also from the same university of David Butler, he evolved the neurodynamics. So he said it's not just about the tension component, neural tension alone. It is neural sliding also. Sliding means the nerve actually moves on the underlying surface. We are not elongating the nerve, we are enabling the movement of the nerve, for which you might move in a combination which might involve a proximal component with the distal component moving simultaneously, where the proximal component is loaded and the distal component is offloaded. When the distal component is loaded, proximal component is offloaded. So his treatment was popularly received all around the world. His group Neurodynamic Solutions, together with Butler's Neuro-Orthopedic Institute, both of them are distributing the courses on neural impairment-based treatment approaches. Of course, Butler evolved or improvised his neural mobilization to include the nerve palpation and massage, and also the central nervous system role in nerve pain as graded motor imagery and explain pain. programs when he started working with Lorimer mostly. So there are a lot of developments. This is the thing which actually exists in the manual therapy scenario all around the world. All these techniques have been studied for their evidence, and equivocally, every study found that the effectiveness of manual therapy is nothing when it is used individually. So that means you can't compare a Maitland concept with Mulligan concept, mainly because Mulligan is indicated for a functional problem. Patient has problem with squatting, stair climbing, sit to stand, like that. Maitland's is indication for a structural problem, like patient is not able to bend and extend the knee in supine lying position. There's a big difference in the indication itself. So how can you compare these techniques? Okay, so they cannot be applied on a same patient, because either I will have supine lying, my knee bending problem is there, or stair climbing problem will be there. If I am having problem knee bending in supine, you will give me Maitland. Whereas I am not able to climb the stairs, you will give me Mulligan's. If I have both the problems, your concern will go to my supine lying problem, because in lying down position only I am unable to bend my knee. How can you train me for climbing the stairs? So there the Maitland becomes the priority rather than giving the Mulligan there. So because of this, these techniques are not comparable at all. So always never focus your thinking into which technique is better for OA knee. Remember, osteoarthritis of knee is a multidimensional spectrum. The condition can involve articular impairments, myofascial impairments, and even saphenous nerve or femoral nerve neural impairments. So you can use Butler's technique if the neural impairment is there. You can use the myofascial techniques if the trigger points in the iliotibial band is there, or popliteus is there. And you can use the articular techniques depending on whether structural problem, Maitland, functional problem, Mulligan, combined movement deficits, Edwards, even McKenzie you can use for the posterior capsule tightness. So it is depending upon the mix and match approach, where the impairment will indicate the treatment approach, not the disease condition. Then the necessity arose that to improvise the evidence, we need a different perspective. We can't be focused on the techniques and train the individuals as certified practitioners, certified instructors, and ultimately they are focusing the A to Z of that technique, be it mobilization or mobilization with movement or mechanical diagnostic therapy, myofascial releases or kinetic control or neurodynamics or neural mobilizations. But they are unable to adapt it and adjust it to suit the clinical presentation. So that mixing and matching highlighted the missing gap in the clinical spectrum where patient-centered approach is required. So this stimulated AOMPT to evolve a combination of techniques, because evidence tells that when you use combined techniques, they are much better than individual techniques. How do you combine that? It depends upon the patient's presentation. So patient-centered and combined application of techniques. So combining the articular techniques, the 5 techniques, what we mentioned as manipulation, mobilization, mobilization with movement, mechanical diagnosis and therapy, and of course combined movements, all of them articular. AOMPT introduced the ortho manual therapy. Combining the myofascial techniques like myofascial release, positional release, muscle energy technique, and motor control retraining, AOMPT introduced the myo-manual therapy. Combining the neural mobilization with the neurodynamics, Butler and Shacklock, along the clinical presentation or patient-centered application as the myo versus the neuro-manual therapy. All these approaches, arthro, or myo, or neuromanual therapy, have so many years before it was introduced by AOMPT. But still we found that patients come with combined impairments. They have an articular dysfunction with the myofascial dysfunction and minimal involvement of neural. In a patient with radiculopathy, they have a disc bulge. They also have a muscle spasm. So not only neural, it is articular and myofascial, all are existent. And all structures are working together, both in function and also in disease. So that is the reason for introduction of another patient-centered approach called as the arthro-myo-neuro-manual therapy, AMNMT. So it's a much broader, complex, I can say, but it is a multi-structural integrated manual therapy application. Problem do not solve with this. Every technique has to also be improvised, because the focus of technique-centered should change to patient-centered in every technique. The best example is the mechanical diagnosis and therapy, which involves positions and movements, which is predominantly the kinematic aspects. But they don't include the muscle action and the kinetics. So incorporating that kinetic portion with the kinematic, AOMPT introduced the mechano-functional diagnosis and therapy, which was again renamed into kinetic and kinematic diagnosis and therapy. Similarly, we have myofascial techniques, which is only passive techniques, but there is no muscles activation there. Without an active force or without a muscle activity, how the release will be maintained in functional activity? Because functional activity involves active muscle contractions. Because of that, it is not just that passively we release the fascia from the muscle. We should activate the muscle and ensure that muscle is released from the fascia so that the muscles can also work effectively. So that is why fasciomuscular release techniques, improvisation of MFR using active muscle forces as fasciomuscular release and FMR techniques. Of course, there are, without any modification of names, we have improvised the Maitland concept, we have improvised Mulligan's, we have improvised the muscle energy. But the motor control retraining requires more improvisation in functional orientation, because we can't postpone the functional recovery. We can't tell the patient that you can do squatting afterwards. It is important for us to train the patient the actual problem on day one itself. If that particular position of squatting could not be adopted by the subject, modify the squatting, modify the starting position to a previous developmental sequence to ensure that functional training starts from day one, incorporating the motor control principles and also the other manual therapy, articular or myofascial techniques or even neural. That approach, improvised approach of the AOMPT, is named as the functional neuromuscular stability training. So that's a very, very beautiful approach, FNST. The recent developments, I have taken this e-training session on fasciomuscular release for Indonesian participants. I'm also taking the functional neuromuscular stability training for the same participants next weekend. We have all conducted courses on every technique, every approach, on AMNMT, FMR, FNST. We have incorporated to ensure that this technique-centered paradigm changes to patient-centered paradigm. Neuromanual therapy is more than sufficient. And again, improvisation included multifaceted treatment techniques integrated together with the neural techniques. So AOMPT, it's not just about the technique focus. Afterwards, the evolution of courses went into what is called as the region-based administration. We had certification courses on spinal manual therapy, how we can integrate all the techniques for utilizing for patients with neck or back symptoms or even thorax. Similarly, we have the pelvic manual therapy specialist for the pelvis region, including coccydynia, pelvic floor myofascial pain syndromes, sacroiliac, iliosacral, and pubis symphysis dysfunctions. Thoracic manual therapy specialist separately for ribcage dysfunctions, thoracic spine dysfunctions, intercostal dysfunctions, what and what not, even sternal dysfunctions and chest wall deformities. Cervical spine specialist for disorders of the cervical spine, that is to do with cervical radiculopathy, thoracic outlet. We have for cervical myofascial pain syndrome, facet joint syndromes, every disorder, pathomechanics and manual therapy with intense master classes. Lumbar spine specialist, do not miss that. It solves all the mysteries about the low back pain, where you can apply all these manual therapy techniques, both the traditional one, the evolving one, plus the newly added ones introduced by the AOMPT. And patients were shown what is called as the clinical or patient-centered approach. All these specialist courses, which were regional ones, also included the utilization of taping, both rigid taping and kinesio taping as adjuncts, plus the cupping, and plus the IASTM, instrument-assisted soft tissue mobilizations. Don't forget, cupping also we improvised into therapeutic cupping. IASTM we improvised into therapeutic IASTM, and taping, kinesiological or the rigid taping, both have been again used along the patient-centered decision making. And we actually justified that we are not providing training on techniques. We are not providing training on treatment approaches. We are providing training as a professional discipline of manual therapy by adding on with all these adjuncts in every session. And then the major additional qualifications based courses, which earlier was the training courses, that was the mastery certification in manual therapy and the online certification in orthopedic manual therapy, the OCOMT, which was in the beginning fully video based courses, were again now added with the certification courses to come up as the fellowship courses. So fellowship of orthopedic manual therapy, fellowship in neurological physical therapy, fellowship in sports physical therapy. So these courses again have come with giving you a weightage as an added qualification, not just as an additional training. Fellowships were introduced in 2021, okay, the last year. This year, what are we coming up with? We are coming up with case demonstrations and case-based masterclasses directly, and patients through tele-rehabilitation. Within 24 hours, we are having the session, the certified tele-rehabilitation specialist, to empower physical therapists to provide the effective treatment along orthopedic, neurological, or cardiopulmonary domains via an online platform utilizing the technology, which is the necessity due to the pandemic and also the global market and its scope. Remember, AOMPT also strengthened the domain of manual therapy more rather than getting the individual emphasis on the treatment approaches by incorporating osteopathy's technique like cranial osteopathy or craniosacral therapy have been improvised into cranial osteo manual therapy. which was again a specialist course, the 2 months course, which was conducted in 2021. We are also coming up with a similar, the visceral osteopathy with visceral manipulation have been improvised into viscerosomatic manual therapy. What and what not? We have been improvising many of our courses thanks to the enthusiastic core committee who have been applying the improvised techniques on patients and coming up with case webinars. The core committee members, their inputs have always been considered whenever we are using a better improvised instruction methodology for all these patient-centered treatment approaches. So remember, the VSMT course is also beginning, and we are having this, the VSMT begins from Monday, this just another 48 hours, whereas the telerehabilitation course is within the 24 hours. So it's my responsibility to extend my invitation to all of you who are watching this to ensure to utilize the platform that is provided by the Academy of Orthopedic Manual Physical Therapists, including the number of free videos and the extent of knowledge and the content that is shared in YouTube here, adding on to the videos in Instagram and also the volumes of webinars and the videos which is provided on Facebook page. So utilize this. Also remember to upgrade your skill by joining the AOMPT as a member. So be a student or you are a professional from any part of the world, you are welcome to join the AOMPT as the members and avail the courses at special discounted fees. Free content is always, it's open for everyone, but remember that the certification courses will definitely upgrade your skills beyond your expectations, which you can see from the 5-star rating of all the course participants that is provided on the Facebook page of AOMPT. So what I would like to emphasize here is to ensure that such a global academy, which is also the official scientific partner for the Journal of Manual Manipulative Therapy, JMMT USA. Most importantly, in the December 2020 issue of JMMT, they have done a global survey and they found that in India, the only active academy providing manual therapy online education throughout the COVID-19, the first wave of lockdown, was AOMPT. But AOMPT did not get content with the whatever the initial achievements, because we believe achievements is not the end of the process, it is just the beginning of the process. So now AOMPT is leading the world in providing online manual therapy education. We are also coming up with an advanced course of lymphomanual therapy certification, which is beyond the lymphedema therapist or the manual lymphatic drainage, incorporating and targeting the immune system, which is the need of the hour as we are entering into the third wave and long COVID scenario. We are always coming up with more and more innovative courses, and stay tuned with the academy to upgrade your skills and pursue your passion towards global excellence. Yes, what we received in the chat, it's always good to see some good evenings. What type of exercises in CP patients for neck control in the age of 16-month girl child? Remember, whenever you are treating a pediatric population, don't see the region. Okay? When you are seeing as a milestone neck control, first of all, although the problem is motor, evaluate the sensory profile. Why the baby is not lifting the head, why the baby is not focusing on the objects, why it is not exploring might be due to an accompanying sensory issue. So that is why sensory integration gets the priority before doing the motor training utilizing the neurodevelopmental therapy. So remember and upgrade necessarily. I have one doubt: how to assess and treatment patient for cervical radiculopathy. As I was highlighting that radiculopathy could be articular, myofascial or neural. So you need to upgrade your knowledge in every aspect of the skills of all the manual therapy techniques. For that, AOMPT is also providing the Certified Manual Therapy Practitioner (CMT) course. For clinicians, the CMT is very useful for interns and fresh graduates of BPT. But if you are an experienced clinician, you want to get the feel of how the AOMPT is providing a patient-centered manual therapy application, you can take another package, that is Certified Musculoskeletal Practitioner. We have 10 conditions, 10 clinical masterclasses with pathomechanics masterclasses. Name of those conditions: thoracic outlet syndrome, frozen shoulder, shoulder impingement syndrome, lateral epicondylalgia, hand rehabilitation, piriformis syndrome. You have knee, osteoarthritis knee, ankle sprains, and plantar heel pain, including even coccydynia as a separate masterclass. So all this will open your highlights. As I was telling about certified cervical spine specialist, where we had cervical radiculopathy, 2 hours of manual therapy demonstration with 1 hour of pathomechanics lecture with differential diagnosis for radiculopathy. Because radiculopathy can be caused by osteophytes, which is secondary to degeneration and spondylosis. Radiculopathy may be caused by the disc injuries and lesions. Radiculopathy may be caused by the nerve root traction injuries or the nerve root adhesions and scarring. So you can have multiple spectrum in the same patient of radiculopathy. And it's important to note that upper cervical versus lower cervical. C5, C6 nerve roots, which will behave as median nerve distribution symptoms with positive upper limb neurodynamic test 1. Whereas the C7, T1 nerve root disturbances will show positive ulnar nerve, the ULNT 4, upper limb neurodynamic test 4. So the variations ensures that you have to evaluate every patient. Don't go by the theoretical information that is there in the textbooks or the technique-centered paradigms. So take the courses of patient-centered application of cervical spine specialist. Definitely you will get the best idea how to individualize your treatment for every type of patient presentations. Okay. Acute lumbar strain. Remember one thing, whenever you are talking about evidence-based treatments, it's senseless. Okay. The one word which I can tell equating to evidence is because all this evidence has been tested on American population, Australian population. It is not at all applicable for our Indian population. Okay. And the next thing with those evidence is every research considers only a narrow spectrum of patients. If you see any RCT, the randomized control trial on low back pain, manual therapy, or lumbar strains, you will find that they would have chosen patients between age group 18 to 55 or 35 to 55. So if a patient comes to us with 65 years, we can't apply that evidence to us, this patient. And the same way, conditions, inclusion criteria might also be telling that visual analog scale pain less than 5, and they would have given the manual therapy. So that research is not relevant for our clinical practice, because you need to see that patients with 9 or 8 intensity of pain also we should be able to treat. For that there is no evidence, because the research do not choose patients with serious and severe pain intensities. They choose what they are comfortable with. That is why AOMPT's courses have a difference there. Lumbar spine specialist course highlights you can take myofascial pain syndrome masterclass in that lumbar strain, or it is the lumbar instability because of ligament strain, or is it the what is called as the fascia joint dysfunctions due to capsular strain. Everything comes under the lumbar strain. And the lumbar strain non-specific can come from pregnancy-related low back pain, obesity-related low back pain, and also the limb length discrepancy or scoliosis-related low back pain. So it's essential for us not to see as a lumbar strain. It's important for us to see what is that clinical presentation which is leading to that lumbar strain. So that is why our focus is patient-centered. What we treat is the dysfunction, not the disease condition. Name of the disease condition will vary between country to country, discipline to discipline. Orthopedician will term it as lumbosacral strain, whereas as a physical therapist, you need to see what are the pathomechanics there. You can't go behind scientific evidence alone and treat your patients. Sorry to disappoint you, but remember, this is the global truth, that reality is not researched. What is researched is not reflecting the reality. So do not search for articles and evidence bases. Search within yourself on whether your knowledge is sufficient enough to understand that particular patient. So upgrade your skill first. Understand the patient first. If you are understanding the patient spectrum, different spectrum can lead to the lumbar strain, then only you are actually training yourself as a sensible physical therapist, rather than an evidence-based physical therapist who is looking at research and treating the patient, rather than looking at the patient and apply the combination of techniques. Just because the research is telling it is not effective, it does not mean that the technique is not effective. It is only those authors, they didn't find the effectiveness. You should analyze why it is not effective and see that you can combine different techniques and make an effective combination. It is also your responsibility, after using it on patients and you have seen that it is effective, you should report that as a case report. Publish your clinical practice findings so that you are establishing what is called as practice-based evidence, which is ultimately the goal of AOMPT and its core members. We are not going behind evidence-based practice. We are going behind practice-based evidence. Every patient improvement is an evidence. So that we have to publish it. That becomes practice-based evidence. So from an India or our developing country perspective, if all our physical therapists in India are documenting properly and publishing their clinical experience, that becomes practice-based evidence. That actually will reflect the reality in India, whereas any therapist in India can safely take those published findings and use it in our routine practice. So practice-based evidence only is applicable for reality, because evidence that is generated from reality, okay, not the evidence-based practice, which is a laboratory and narrowed thinking. A researcher thinking comes there in evidence-based practice, Whereas in practice-based evidence, it is clinician thinking process comes, which is ultimately the patient-centered thinking. Okay. So what I would wish to encourage all the participants who are watching today is to enroll in the courses of AOMPT. If you need more evidence, please watch the free content that is available in this YouTube channel. You will definitely get more than enough confidence or evidence in front of your eyes. Your conscience will tell you that no other academy provides this much depth of education and learning. Every video you will find that it is so much useful for your lifelong clinical practice. So when you watch them, do not hesitate to take the decision of your life. Join the AOMPT, enroll in the courses. Make sure that the world, especially India, should know more and more of such quality knowledge. Especially when the world knows it, it's the responsibility India also should know it. Okay. So I wish all of you the best of your decisions, and of course the 2022, which is going to bring you all the best things in your life. So God bless you all, and I take this opportunity to also thank your presence and appreciate your queries and inputs that were shared through the live chat. So good luck to you all. See you. Stay rocking. Ensure that whatever techniques you learn, it should strengthen the physical therapy domain. And don't forget, manual therapy itself is a professional discipline. It should be strengthened, not getting weakened. So examples of weakening is utilization of cross-professionalism. So you learn another profession technique, you get identifying yourself as another professional, and without adequate qualification, without doing a doctor of chiropractic, without doing a doctor of osteopathy, do not tell that certified osteopath. Okay? There also certified osteopath never comes there. It is only a qualified osteopath. Qualification should be DO and DC for qualified chiropractor, qualified osteopath. Never use the word certified osteopath. Because you can't tell I am a certified physical therapist. Imagine an osteopath DO is doing a physical therapy course for 3 days and he puts that certified physical therapist. Will you agree? So similarly, do not do a 2-3 days course of osteopathy or chiropractic and do not lose your physical therapy identity and get a fake identity of certified osteopath or chiropractor without doing DO or DC. If you do that, you can say qualified osteopath and qualified chiropractors. It's available online also. DO and DC anybody can do. Okay? It's just about money. You don't have to do any kind of evaluation formally. Nothing is there. So what's important here is to ensure that all courses of AOMPT are provided only for physical therapists. So we want to strengthen the physical therapy domain and manual therapy professional discipline. So that is the reason why all our members, we have osteopath members, but remember that they are doing only the osteopathy related courses of the AOMPT. Next comes to the laws of the land, the local governing laws. Okay, so be always important, verify, ensure that the state council in India or the regional licensing body anywhere in the world should have listed these techniques in your treatments. Then only use techniques like dry needling. Specifically, I am highlighting about dry needling is because it's an invasive treatment technique. It is not, everywhere is not UK. Where UK they have included the dry needling under the scope of practice in physical therapy. But everywhere it is not the same. So ensure that when it has adverse effects, whether it is really necessary, manually you cannot treat the patient, you have no other option, tissues not at all having any circulation, the trigger point, and it is fibrosed, then you use the dry needling. Otherwise, there is no necessity for it. As long as you have the pathomechanical reasoning to utilize the active forces and apply it as fasciomuscular release techniques of the AOMPT. Okay, cupping is also there, non-invasive. So remember that various techniques could be used in combination, and if you don't find the result, then you use the invasive techniques, provided legally it is permitted and allowed. Do not use the technique just because you got trained or certified. Check with the local law of the land. Okay. So that's about the final do's and don'ts, and wishing for a long lasting collaboration with all of you, and ensure that the collaboration is for the purpose of global excellence. It's not just the excellence because an individual is feeling that you are excellent. I feel I am excellent. Whole globe should tell what I am doing is excellence. That is global excellence. So that is the mission of AOMPT. So good luck to you all. See you. Bye bye.